My name is Brooke Hensley, and today I'm going to talk about the FAST exam, pearls, and pitfalls. And the goal of this lecture is to really emphasize that as emergency physicians, we are the experts of point of care ultrasound, and the FAST exam is no exception. Clearly, this FAST exam on the right is floridly positive, but as experts in point of care ultrasound, we have to be able to pick up on the small subtleties of hemorrhage in trauma patients and make good clinical decisions based on our exam. This lecture is not going to cover patient positioning, how to use the machine, literature review, etc. More specifically, we're going to go over image review of easy misses, fake outs, and the importance of fanning while acquiring your images. In this first example, we are in the right upper quadrant. You see the liver here, Morrison's pouch, and the right kidney. And it looks like it's negative. However, this is actually an indeterminate study because the fanning is inadequate, and more importantly, I don't see the inferior pole of the right kidney. This next clip is the exact same patient, but with further interrogation and fanning of the inferior pole of the right kidney, and you see positive hemorrhage at the tip of the liver and the inferior pole of the right kidney. As you can see, it would be extremely easy to call this negative, especially when looking at just the beginning of this clip. This next example, you see that Morrison's pouch actually looks completely fine. There's no blood here, but you only see blood at the inferior pole of the right kidney. And also you see this heterogeneous appearance of the liver that's concerning for hemorrhage or clot. In this example, to improve this image quality, I would decrease my depth and I would definitely increase my fanning. This would also be an indeterminate study in terms of fanning and in seeing the inferior pole of the right kidney, but you can actually see that there's a small amount of blood right here, and this is a positive FAST. This would be easy to miss because most of Morrison's pouch here actually looks completely fine, but we have to pay attention to the small details. This example, we're also in the right upper quadrant, and I don't see any blood above the diaphragm. Morrison's pouch looks okay, I don't see anything there, but I see this suspicious area between the liver and the kidney here. And what this is actually perinephric fat, and the way you can tell is because there's some echoes within it, and you see this double line sign, which is a very sharp demarcation around the kidney and around the liver. If this were clotted blood or hemorrhage, you would not see this nice sharp double line sign. Obviously not everybody has perinephric fat, but if you see enough of these and recognize this as such, I've actually made this mistake in the past and called this a positive FAST when it was just perinephric fat, so we have to be really careful and identify this. The take-home point for the right upper quadrant is you really have to do a good job of interrogating the inferior pole of the right kidney, and you have to do a really good job of fanning to interrogate the entire space. Here we are in the left upper quadrant. You see the kidney here and the spleen up here. And the splenorenal space actually looks okay, but there's something up here that looks suspicious. But it's difficult to tell because, again, there's no great fanning going on here. So this next clip is actually the exact same patient, but interrogation of the splenic recess. And you begin to see here that it becomes more obviously positive, where you see hypoechoic material as well as this hyperechoic material that's concerning for a splenic laceration or clotted blood within this space. Again, a subtle finding, but becomes more obvious when you're doing a better job at fanning through this area. This example, also the left upper quadrant, the splenorenal space looks completely okay. I don't see anything there. But if you look up here, there's this heterogeneous material that is concerning for clotted blood, and also this hypoechoic area over here that's concerning for hemorrhage. This is the ultrasound of that same patient that I just showed you and the CT scan of that patient. Here you can see this splenic laceration and blood accumulating along the side of the spleen. And as you can tell, looking at the dependent portion of this patient's left side, you can see how easily blood can accumulate in this splenic recess long before you'll see blood in the splenorenal space. So this is really important to remember when you're scanning the left upper quadrant, and to not just focus on the splenorenal space. So this is an example of normal anatomy and excellent fanning through the left upper quadrant, but we always have to remember to interrogate the splenic recess, and again, fanning is very important. Here are still images of CT scans of the left and the right sides of the body where you can see the anatomical differences. On the right side, you can see that the potential spaces include not just Morrison's pouch, but the inferior pole of the right kidney, depending on where the hemorrhage is coming from. On the left side, you can see that there's much more potential space in the splenic recess, and much more blood can accumulate closer to the spleen before you see any blood in the splenorenal space on the left. This coronal view at the bottom of the screen, again, you can kind of see how there was much more potential space in that left upper quadrant near the spleen, and how that differs from the right. To kind of bring home this point, this is a 3D reconstruction of the right upper quadrant, showing the potential spaces of where blood can accumulate, and that includes not just Morrison's pouch, but the costophrenic recess, as well as the inferior pole of that right kidney. Alternatively, this is a 3D reconstruction of the left upper quadrant, showing the potential spaces on this side of the body. And that includes the costophrenic recess, the subphrenic area, and finally the splenorenal space, which is oftentimes can be the last place you see blood, depending on where the hemorrhage is coming from. This patient presents to the emergency department with a stab wound to the left anterior chest. For some reason, the portable chest x-ray is completed before you get the ultrasound into the room, and vital signs are crashing. Obviously, there's something wrong going on with this patient. You don't know where the blood is. And technically speaking, if you get a patient with a stab wound to the left anterior chest, the first place you're going to put that probe is around the heart, because that's what's going to kill the patient first. So this is the first image you see. This is the actually parasternal long view. And you see the left atrium, left ventricle, and the aortic outflow tract. This is the descending thoracic aorta, and you see this hypoechoic fluid right here next to the heart. The question is this in the left side of the chest, or is this around the heart? If there was bleeding or in the right side of the chest, you actually can't see that on the parasternal long view. But the way that you can differentiate a pleural effusion versus a pericardial effusion, also in non-traumatic medical patients, is you see where the fluid is in relation to this descending thoracic aorta. If the fluid is posterior to this descending thoracic aorta, then the fluid is in the chest. It's a pleural effusion. If the fluid is anterior to this descending thoracic aorta, then it's a pericardial effusion. This next example is a perfect example of a pericardial effusion where you see the fluid layering anterior to this descending thoracic aorta. This is a side-by-side comparison of pleural effusion here on the left side of the chest, which is posterior to the descending thoracic aorta, and a pericardial effusion where you see fluid accumulating anterior to the descending thoracic aorta. Of course, you can have patients that have both. So you see, again, the parasternal long view with the left atrium, left ventricle, aortic outflow tract, and the right ventricle. And you see the descending thoracic aorta, and you see fluid both posterior to the descending thoracic aorta and anterior. So this patient has both. If you are unsure if you have fluid in the pleural cavities, you can look in the left upper quadrant, right upper quadrant of your fast view and look above the diaphragm. Here, we're in the right upper quadrant, and I don't see any blood in the abdomen. Morrison's pouch looks okay. I don't see anything suspicious there. However, I do see this anechoic fluid above the diaphragm right here. And normally in a well-aerated lung, you see this mirror image artifact above the diaphragm, meaning that when ultrasound beams come down and cross over the diaphragm, you see what looks like potentially another liver on the other side of it, and that's why it's called a mirror image artifact. However, whenever there's any fluid consolidation or blood in the chest, you lose that mirror image artifact, and that's why you see this anechoic fluid here. In addition, you see a positive spine sign. And what I mean by the spine sign is you see this white ridge along here at the bottom of the screen, right here, and that is the spine. And it's normal to see the spine along here, but it should end right when the diaphragm begins. And whenever you see the spine sign continuing above the diaphragm, that means that you have either fluid consolidation or blood in this space here. So here this patient has a positive pleural effusion or hemorrhagic effusion above the diaphragm. In this image here, it's a little bit grainy, but you see something that's a little bit suspicious for a possible pericardial effusion here, anterior to the right ventricle. Everything looks a little bit grainy, so you're not really sure if that's truly fluid or a fat pad, and this is exactly why you have to get at least 2 views when doing a cardiac exam. This next clip is the same patient but a parasternal short view. This is the left ventricle at the level of the papillary muscles and the right ventricle here. Again, you see this area that's a little bit suspicious for pericardial effusion, but again, it's only anterior to the right ventricle. It doesn't track down along anywhere else around the heart. There's no disappearance of this possible fluid during end diastole, so I would be suspicious that this is actually, in fact, a fat pad. In this example, on the left side, this is an apical 4-chamber view with the left ventricle, left atrium, right atrium, and right ventricle. And here you see a very small amount of fluid tracking along the left side of the heart. But again, if you're unsure, you need to get a second view. Here, this is the parasternal short view, left ventricle, right ventricle, and again, on the second view, you see a very small pericardial effusion. So the take-home point for the cardiac view is you need 2 views at minimum. Even if you're doing just a subxiphoid view for the FAST exam, you will not get credit for the exam when you record those images when we're doing our QA, and we will give you a technically limited study as a score. So always remember that you have to have 2 views at minimum. Here we're looking into the pelvis, and we're looking at a very full bladder, and the scanning is pretty good. The person who's acquiring this image is doing a really good job of fanning slowly, making sure the entire area is interrogated. I don't see any blood, and I would actually call this view negative. However, this next view is the exact same patient, but a longitudinal view. And most of it looks negative to me until the very end. I want you to draw your attention right here. And right at the end of the fanning, you see a very small amount of fluid here. And also at the bottom of the screen, right there, just for a split second, you see positive fluid there. So the take-home point for the pelvic view is you need at least 2 views, and at very minimum, you need the sagittal view because it's more sensitive for free fluid, and make sure you fan the entire area. So take-home points of this lecture. For the right upper quadrant, you must interrogate the inferior pole of the right kidney. For the left upper quadrant, you need to interrogate the splenic recess, the tip, and diaphragm. For your cardiac views, you need 2 views minimum. For the pelvis, you need 2 views and at least a sagittal view because it's more sensitive. Remember your fat fake outs around the heart as well as around the kidney. It's okay to use the term indeterminate, and in fact it's encouraged. Just because you don't see anything positive does not mean the study is negative. It's only call it negative if it's truly negative. You got all the views you could and you interrogated and fanned completely. And always remember to fan. Thank you.